water-soluble contrast before CT scans can give us a CT DCG, dacrocystography. Now we move to etiology of lacrimal sac and duct obstruction. It's either congenital, and we have discussed this. The sac goes to the nasolacrimal duct, to the inferior meatus, and usually due to failure of recanalization at Hasner's valve. This gives rise to congenital nasolacrimal duct obstruction. Other nasal pathology, like nasal polyps, can lead to congenital nasolacrimal duct obstruction as well. In adult or acquired causes for obstruction of the sac or the duct can be either inflammatory, neoplastic, any neoplasm in the area of the lacrimal sac or the lacrimal duct or the surrounding nasal tissues or orbital tissues can lead to obstruction. That's why endoscopy is important in assessment of such obstructions. Cases of trauma and surgical trauma, like facial fractures, rhinoethmoidal fractures, post-surgery, like post-rhinoplasty, which is very common nowadays, or orbital surgery. For the inflammatory causes, it might be either non-specific or specific. Remember, we are discussing the sac and the duct. So inflammation of the sac would be dacryocystitis. This is the next topic we'll be discussing. Or inflammation, non-specific inflammation of the duct itself. This is commonly non-specific inflammation, something that just takes place. It's very common in old age women, old age females, usually of low socioeconomic status. This inflammation happens in the area beneath the sac, in the upper nasolacrimal duct. It starts in the early phase by vascular engorgement, congestion, and lymphocytic infiltration. With recurrent inflammation, the late phase involves fibrosis and stenosis of this segment. The second most common location for such non-specific inflammatory stenosis is the area of Hasner's valve, usually ascending inflammation from the nasal mucosa. Always remember that histologically, this area has features of respiratory mucosa, just like the nose. So it's very easily acquiring infection from the surrounding nasal mucosa. This is different from the microbiology of dacryocystitis, from the Haemophilus influenza in children, from the Staph aureus, and even Pseudomonas aeruginosa. Specific inflammation like Wagner and sarcoidosis, these usually cause granulomatous inflammation, and during management they need systemic cortisone. Of course, the systemic cortisone we are using is prednisolone, not cortisone by name, as we discussed before. So before DCR, in a specific inflammatory stenosis of the nasolacrimal duct, systemic cortisone can be very beneficial. Dacryocystitis.